Good afternoon and welcome to SSMC Answers. My name is Matt Getman, Chief Medical Officer here at SSMC, and thank you so much for joining our program today. As many of you know, SSMC is one of the largest hospitals in the United Arab Emirates, and we are here to treat patients with serious and complex medical issues. We want to deliver comprehensive care, but also do it in a holistic way, where we think about the impact that disease may have on the mind, the body, and the spirit. We believe in a team-based care, and we also want to deliver care with the most compassion possible. We also want to provide patients and family members alike information on common medical illnesses, and when possible, focus in on prevention of disease. In each of our SSMC Answer sessions, we invite experts from our medical staff, and we discuss topics that are relevant to you. Today's topic is lung cancer, and we've selected lung cancer because November is Lung Cancer Awareness Month. And I'm glad today to welcome some true experts from SSMC to the program today. Dr. Pooja, who is our thoracic surgeon, Dr. Daniel Chamberlain, who is our chair of radiation oncology, and Dr. Hassan Sheikh, who is from medical oncology. First of all, thank you all for joining. We'll start the program today. Hassan, can you give us a little bit about demographics? How common is lung cancer in the United Arab Emirates and then in the world?
Yeah, thanks, Dr. Getman, for having me today. It's my pleasure today to be here to discuss lung cancer. So lung cancer is really a leading cause of cancer-related morbidity and mortality. And if you look at the data from GlobalCon 2020, it showed that lung cancer worldwide was the second most commonly diagnosed cancer and number one cause of mortality. In terms of our statistics from UAE, it is the fifth most commonly diagnosed cancer and the third most common cause of cancer-related mortality. So still, it is overall a significant morbidity, and it's an important cancer that we really need to focus on today.
And along those lines, Dr. Pooja, what are the risk factors for lung cancer, and what can we do to prevent lung cancer?
That's a very good question. Thank you for having me. Some of the risk factors are basically exposure to cigarette smoking, midwak, dhoka, even shisha, and even bakur. Believe it or not, all these have carcinogen agents. And so this can put your risk of malignancy of lung cancer very high, in addition to any lung damage and interstitial lung disease, COPD, emphysema. As far as prevention, keep yourself healthy, stay away from either first-hand smoking and even second-hand smoking, and make sure that you are making everything to protect your own children and life in the future.
So if you're a smoker and you hear this message today and you say, I want to stop, what are the programs that we have to help with stopping smoking?
So we have smoking cessation programs that we encourage patients to seek counseling. There are some pharmacotherapy agents that can be provided to the patients in addition to counseling. And if you are a smoker, we highly encourage patients to get screened. We have implemented a lung cancer screening program where patients who fall under DOH criteria, where they qualify for lung cancer screening exam based on the number of cigarettes they've smoked, the age, and the exposure and risk factors that they may have, they qualify for a lung cancer screening exam. What that entails is a low-dose CT scan that's provided under radiology department. And once we review the images and find out what's their underlying problem, we address it appropriately.
So an imaging test to see if they might have changes in the lung that would be associated with growth.
Correct.
Is that the idea, a malignancy?
Yes, absolutely.
Okay. Now, we never want to have anyone diagnosed with this, but what sort of symptoms would patients have that come in with lung cancer?
That's a very good question, Dr. Getman. Unfortunately, most patients are asymptomatic. When you have early stage cancer of anything, you tend to be asymptomatic. So just because you don't have any symptoms doesn't mean you don't get screened. It should always a bad idea if you wait to develop symptoms. If you have any inclination of fever, chills, cough, shortness of breath, hemoptysis, coughing up blood, weight loss unintended, those are all risk factors that you may have an underlying malignancy. If you have a strong smoking history or exposure of cigarettes or any smoke, go seek counseling from your general practitioner or pulmonologist so that they can refer you to a lung cancer screening program.
Okay, so Hassan, let's go to you for a question. And so if someone has these symptoms, then what's the workup that the patient goes through to try to figure out what's going on?
Right, and as Dr. Pooja mentioned, some of these symptoms can be specific to lung cancer, but also can be applicable to other pulmonary pathologies. So it's important to have good imaging studies. So we need a chest X-ray or a CT scan to see if there's any mass in the lung which is causing these symptoms. And then the second part is to have a pathological confirmation of the type of this disease. So broadly, you need a full staging scans and a pathology or a biopsy to confirm the diagnosis. So those would be the two broad areas of our workup.
And how is that biopsy or that piece of the tissue obtained?
Yeah. So we use the help of our colleagues in interventional pulmonology and thoracic surgery and even interventional radiology to find out what is the best approach to approach that mass. This could be either endoscopically through bronchoscopy and endobronchial ultrasounds, or it could be percutaneously via a needle biopsy.
So you might go through the mouth and down into the windpipe and go that way, or it could go through the chest itself.
Correct. Yeah, those broadly speaking would be the two approaches.
And then you get a piece of tissue, and then based upon that look of the tissue, then there's different types of lung cancers?
Right, yeah, so once we have the tissue and we know that this is malignant looking cells, and we do a series of several tests to ascertain the type of the lung cancer. One of the things that we have learned over the last several years is that there are many types of lung cancer, I would say more than a dozen types. And this has to do with their molecular genes, the genes which are driving the cancer. Traditionally, we used to have two types, which were based on the size of the cells under the microscope, so small cell and non-small cell. But then we found out that there are certain proteins which are expressed in certain types, which gives it a more glandular or adenotype or more squamous type. And recently, with the understanding of genomics, we have been able to identify driver genetic mutations. So, for example, a cancer which is driven by EGFR mutation would have a different subtype, it would have a different prognosis and different behavior. So we now classify the cancer according to their genetic makeup as well. So the short answer is that we now have several types of lung cancer, and it's important to know your type so we can provide the right treatment for the cancer.
Now, we have a team of experts here. We have the medical oncology, we have surgery, we have radiation oncology. Dr. Chamberlain, when you are getting a patient that has now a diagnosis, do you immediately go right to radiation, or how do you decide when to do the different treatments?
Great question, and that's why it's important to have the whole team, because the proper treatment for the lung cancer is really going to depend on what the stage is and what the type and the subtype of lung cancer is that's affecting the patient. So to oversimplify this a little bit, we would typically treat a early stage non-small cell lung cancer, so the more common category of cancers. That might be just surgery. So that's the importance of screening, is if we catch it early, the survival rates can be quite good, and it can be treated simply with surgery. If we get into stage 2, it's often going to require surgery and medical oncology. Stage 3, that's where radiation can play a role commonly, with now it's radiation and medical oncology, meaning pharmacological therapies. And then stage 4, mostly pharmacological therapies. They've advanced quite a bit. There's the typical chemotherapy. There are also drugs that target the specific mutations in the cancers. And over the last decade or so, we've really had an evolution in immunotherapy, which are drugs that get the immune system to fight the cancer. You turns your body's own defenses against the cancer. It's been quite successful. So really, there are guidelines for it, but on an individual patient basis, it becomes a multidisciplinary team discussion for each patient.
Sure, and as the number goes up on the staging, the more extensive the disease and the need to think about more treatments.
Yes.
Is that a fair statement?
Yes, and so that's why the need for prevention and for screening is so important, is because when we catch the lung cancer early, or if we can avoid it altogether, obviously, there's just less impact on the patient's life.
Now, we have a low stage disease, Dr. Pooja, then tell us, when is surgery done and how is that done?
So you have to first discuss the options with the patient. After reviewing their imaging, sometimes with the help of multidisciplinary team, which is something SSMC offers, we are fortunate to have all service lines available. We meet on a weekly basis where we discuss each patient who gets diagnosed with lung cancer about what their staging should be, workup should be. Depending on the size and the location of the nodule, they may or may not need a further biopsy and staging workup. And then we decide what surgery is right for them. We offer the patient surgery depending on their lung function status, their overall comorbidity status, as well as whether the patient wants to proceed with that. There are options now that if they did not want to undergo surgery, we can offer radiation in that setting. And they have appropriate good results that are well published now.
So this is really highlighting the team-based approach to care at SSMC and the fact that we talk about each individual case through a multidisciplinary team meeting to come up with the best way of treating things. Now, you've got a robot. Tell us how you use the robot for treating lung cancer.
Great question. So conventionally, these surgeries were done open, where you had this huge thoracotomy scar. The patient
You mean
had
an incision on over your rib cage?
Yes, correct.
Okay.
Huge cut on their chest wall. You had an extreme excruciating pain postoperatively, a longer length of stay in the hospital, longer recovery time to get back to your baseline activities. Over the last couple of decades, we have moved from that approach to minimally invasive thoracoscopic and now robotic surgery. The robot allows us to have extreme high precision on operating on even complex cases where once we felt these tumors were unresectable, you can see these planes in a magnified view in a 3D strategy where you're able to peel these tumors away from blood vessels or even cut a segment of blood vessels and put things together so that you're able to salvage as much lung parenchyma as possible. Patients' length of stay in the hospital is shorter, the pain level is much better. Sometimes some patients say they don't have any pain after surgeries, believe it or not, and they get back to their baseline.
So
quicker.
we're talking about little keyhole incision surgery and the fact that the robot is not doing the work, you're doing the work.
Yeah, that's correct. That's a misconception in lots of patients' minds that, oh, the robot's there, so they'll do all the operating. No,
Yeah.
the robot is essentially a tool for us to do better surgery.
And we're fortunate here at SSMC to have great technology, state-of-the-art technology, state-of-the-art experts, delivering care for the patient. Along those lines, Hassan, from a standpoint of the therapeutics, give us a snapshot. What's happening that's new and exciting? Dan alluded to it, but what are those new things that are happening in your field of chemotherapy?
Right, yeah, this is a great topic, and I could go on and on this area, but in the interest of time, I'm just going to briefly mention the broad categories where we have seen some unprecedented improvement in our systemic therapy. So traditionally, we're all familiar with chemotherapy, which kills the cell directly and has a lot of toxicity or adverse effects, as we know. But what has really happened over the last 10 years is that our understanding of the biology of lung cancer has improved, and now we are able to identify some specific targets in the cancer cells, and these targets could be some proteins or receptors that we can target with an oral pill and stop the cancer from growing. And we have seen some exceptional results with these strategies. So we have now a lot of options in terms of the different types of targeted agents and also the new information about the targets in the cancers.
When you're talking about those targeted agents, you're referring to the body's own system fighting the cancer?
Right. No, so that is the other area of development, which is the immunotherapy part. So we harness your own immune system to attack the cancer cell more aggressively and more robustly. So we have the immunotherapy drugs. These are basically, again, protein antibodies, which really unleash your immune system. And we have seen some phenomenal results in our clinical trials. And I can share my personal experience here that I had a patient with stage 4 lung cancer, history of heavy smoking, and after several rounds of immunotherapy is cancer-free. And I think I share this experience with many other oncologists who have seen such patients. So this was not seen before prior to immunotherapy, and I think that's a really good hope for our patients.
I think that's really exciting to see what's happening on the surgery and on the chemotherapy, immunotherapy side. But then here we are.
Yeah.
We've got the radiation
Yeah.
facility, SSMC, just opened. Fantastic state-of-the-art center. Tell us about that.
Great. So yes, thankfully we have very good modern technology at the Radiation Therapy Center. And in lung cancer specifically, what this allows us to do is a few things. So in the early stage patients, as Dr. Pooja alluded to, some of these patients either don't want surgery or they're not medically fit for surgery. So even with these great advances in technology and excellent skill, some patients are going to have harder lung problems, particularly patients that have a lifelong history of smoking, where they may not be a great candidate for surgery. And over the past few decades, there's been an alternative that's been developed called radiosurgery, which delivers very high doses of radiation very precisely onto the tumor. However, to do that, you have to have the right technology. And so thankfully, that's what we've installed here. We have the equipment to both track the tumor's motion as you breathe, because obviously lung tumors are going to be in the lungs and the lungs are moving continuously as we're breathing. So we need to be able to account for that. And then also to pinpoint that with some additional imaging capabilities on the machine and then deliver that dose directly to tumor. So sometimes patients that might have been in a surgical candidate but couldn't get that for whatever reason, we could treat them in 3 to 5 outpatient visits for about a half an hour each. And it has results that are very comparable to surgery. So it is a very good, the way I describe it to patients, it is a very good fallback option if for whatever reason surgery is not preferable. And on the more advanced stages as well, being able to deliver more precise radiation, what that does for the patient is it decreases scatter dose and low dose to the lungs and the heart. And we know from multiple trials that dose to the heart and lungs is a predictor of life expectancy. So if you have a patient that's being treated with older techniques, the outcomes might not be as good because those are vital organs and we want to spare them any inflammation or other side effects from the radiation. So the image guidance allows us to tailor the radiation much more closely to the tumors.
What about side effects of treatment during radiation
Yeah.
therapy? Is it really tough on patients?
You know, honestly, for most patients, it's not. So it depends on the stage and what we have to do. But for early stage patients, they tolerate it quite well. There's always a risk of, if we're doing radiosurgery, if it's near ribs or chest wall, there's risk of chest wall pain afterwards, similar to how you'd have chest wall pain after surgery if you had to go through that wall. A lot of patients are just fine and don't have much in the way of side effects. But yes, with either radiosurgery, particularly when you're treating something larger, like a larger stage 3 cancer, we worry about the impact of the heart and lungs. And so we have to be very careful. We do have safety parameters set up and we do have very precise equipment that allows us to meet those parameters. But you can have inflammation of the lungs either from the radiation or sometimes from pharmacological reactions that can be a serious side effect.
Now, Hassan, you mentioned that patients nowadays are taking pills as opposed to doing traditional chemotherapy. What's the side effect profile with those medications?
Right. So one thing I wanted to also emphasize with these targeted therapies that their side effect profile is much different than the chemotherapy, and different in the sense that it's better, it's better tolerated, and it's convenient to take. For example, one of the targeted agent would only cause maybe a mild rash and a little bit of diarrhea, which is easily managed with symptomatic medication. So patients really report good quality of life on these medications. And I think that's a great benefit to our patients.
And Dr. Pooja, you said for patients that are undergoing surgery, oftentimes no pain at all or very little pain.
Correct. We have an expert team of anesthesiologists. They provide phenomenal coverage with regional blocks, so their pain level is very well controlled. And it's a team effort. You know, everybody combined all the way from pre-op to post-op recovery. It's such a streamlined process at our hospital. The beauty of our hospital is that we've got comprehensive care. All service lines are here. Patients can come and get one-stop shop treatment. And the patients overall are very pleased with their operative outcomes.
And if patients are recovering from surgery faster, then that's allowing them to get to Dr. Chamberlain, Dr. Hassan, and to get additional treatments that they might need as well. Is that a fair statement?
The fair statement is that they are able to have a good recovery with minimal risk of complications, and they're able to complete their treatment. The timeline process is quite fixed, so after recovery from their surgery, usually if they are qualified for adjuvant therapy, meaning post-operative therapy, that's usually done 4 to 6 weeks after surgery to allow them to completely heal. So that timeline process is fixed. However, more and more patients are able to reach that.
Makes sense. Okay. We're going to go to some questions that are coming in. And the first question, Dr. Chamberlain, are there specific tests or markers that determine how a patient will do that's diagnosed with lung cancer?
Yes. So, and to simplify this, there's the stage, and then there's the tumor features that we see under the microscopes. The stage is anatomically how large and how widespread the cancer is, and obviously catching it earlier before it has spread, before it has grown, leads to better outcomes. And then, as Dr. Hassan was talking about, there are specific markers. So there's a subtype. There's different types that are more or less aggressive. But then within that, if we find a lung adenocarcinoma in a patient and a lung adenocarcinoma in another patient, say they're the same stage, a patient that has certain markers on those cells, even though it's the same subtype of lung cancer, is going to do better because there'll be more drug therapies that can target that tumor. So if they have an EGFR mutation, for example, there are drugs that target that are going to provide a better outcome.
Okay. Hassan, one question for you. What tests are needed to determine the stage of cancer?
Right, so this is related to our staging workup. So as I said, usually we do a PET CT scan and an MRI brain to fully examine the whole body. But if for some reason PET scan is not available, you could also do a CT full body with contrast to get the full staging.
Okay.
Yeah.
Dr. Pooja, if lung cancer is detected early, is it easily treated?
Yes, short answer is yes. Of course, it depends on comorbidities, it depends on your overall functional status. But for the most part, we can offer resection, which is the standard of care. Once the tumor is removed and you've done an appropriate lymph node dissection as well to stage the patient's tumor, you can have a very good overall survival depending on your final pathologic stage.
It's never easy to hear the word cancer. How do we all support lung cancer patients after their treatment or even during their journey? What sort of support groups do we have for this problem?
So we have we obviously have to be compassionate. You're absolutely right. You can never put yourself in patients' shoes. The number one thing is we offer the patients any social support. I do counsel them that if they wanted to speak with a patient who has undergone this surgery in the past, with their consent, if they want to reach out to anybody, they can. As long as both parties agree, they will be able to speak with each other. And we, like I said, we have an internal support system with nurses, ancillary staff, both in the ICU and the hospital ward, where we have nurses and staff and liaisons who will help them cope with this diagnosis.
Thank you for that. A question coming in is, are there lifestyle changes or complementary therapies that can support treatment? Hassan, what do you think?
Well, certainly there are lifestyle changes that can support prevention, and that includes having a healthy diet and good exercise, quit smoking, minimize alcohol intake. Those are just a simple measures that everybody can do to improve their health. In terms of complementary medicine, so again, we don't have high quality evidence-based scientific studies showing that any particular substance or any medicine could prevent lung cancer. So we don't have any particular recommendation for that. But our general recommendation, as we all discussed, was to quit smoking if you're a smoker and have a healthy diet and a high activity level.
We've already kind of, discussed this question, but the question that is here is surgery always required to treat lung cancer? Dan, what do you've answered
Yeah,
this.
the short answer is no.
Right.
And so, yeah, there are alternatives to surgery, but as Dr. Pooja mentioned, if it's appropriate for the patient, it is the gold standard, but there are good alternatives if it doesn't work out that way.
Now, another question coming in is about immunotherapy. They want to understand more about what is immunotherapy and how does our body attack cancer?
Right, so there'll be a lecture on science here, but I'll just try to simplify. So our immune system is composed of B cells and T cells. So these are the cells which have a surveillance in our body. Anytime any cells goes haywire, these cells will identify and they'll break it down and reprocess. Cancer, the way cancer develops is that it learns to evade our immune system. So it will not let itself identify by the immune cells. So these immunotherapy agents that we use, they actually block those receptors on the tumor cells as well as on the immune cells, which promote the early and more intense identification of the tumor cells. So that's how the immune cells can attack the tumor cells and lead to the essential reaction that is needed to kill the cancer cells. Yeah.
Dr. Pooja, another question. Are there other treatments beside robotics that are changing the way surgery is done?
It's a loaded question. Yes and no. There's a lot of work in artificial intelligence being done to see if.
What's artificial intelligence?
It's essentially by employing prior protocols, prior imaging, we've been able to come up with a new protocol where you can identify cancers differently. Perhaps you can, for example, you can have a patient who comes in with a chest X-ray. Having done the homework before in the past where you've correlated what findings will you see on a CT scan that correlates on a chest X-ray, perhaps just by looking at chest X-ray, we can predict what are the chances that this patient may have an underlying malignancy. Based on these things, there are new things on the horizon that are able to identify lung cancer early. And as far as treatment, there are few and far between. There are a lot of people who talk about endoscopic or bronchoscopic treatments from inside the airway without having to make an incision, so incisionless surgery, or incisions through the diaphragm. Those are surgeries that are done in few and far between centers around the world.
Dan, a question for you that's coming in. Radiation therapy is delivered while the patient is breathing. How can you be certain that you're accurately targeting the tumor while this is happening?
Great question. So the radiation treatments are delivered based on a treatment plan with a specialized CAT scan that we take in our department. And that CAT scan, unlike a diagnostic CAT scan that's a snapshot in time, there's like a video CAT scan that records how the tumor moves as the patient's breathing. And so we know that we're encompassing the full excursion, the full movement of the tumor over the course of the respiratory cycle. And with that information, we can do a few different things. We can either say, okay, the tumor's not moving that much. We're going to account for that movement and include all of that in the target area. Or if the tumor's, say, near the diaphragm and it's moving much more, we can do some things to train the patient and use some abdominal compression to limit the movement, so they're breathing more from the shoulders, not moving the tumor as much. Or we can have our machine do what's called gated treatment, where we only treat the tumor during certain portions of the respiratory cycle. So when the patient's lying on the treatment table, we have CT imaging, and we also have surface guidance imaging. So we're going to know how much they're inhaling and exhaling throughout the treatment.
This is great. I think, we don't want any patient to ever be diagnosed with lung cancer, but this discussion today verifies to me that if they are diagnosed, that coming to SSMC, to me, is a no-brainer. We've got the experts, we've got the technology, we have the compassion. We want to have patients have that holistic approach to their treatment journey. So I think we have the whole thing. And this has been a great discussion. We'll wrap it up today. I'd like to again thank Dr. Pooja Khaitan for joining us from thoracic surgery, Dr. Dan Chamberlain, who's our chair of radiation oncology, and Dr. Hassan Sheikh, who is from medical oncology. My takeaway is prevention. Stop smoking, avoid secondhand smoke, and those other environmental exposures. And I would say that screening that you mentioned is going to be critically important, because oftentimes lung cancer is going to be asymptomatic. So with that, we'll wrap it up, and thank you so much for this great discussion today.
Thank you.
Thank you.